I hope everybody can hear me. Sorry for the delay. I was stuck in a case. Just got finished at 7:15. So I got this request for embolizing agents, though we have covered most of them separately in each of the type of cases where which kind of embolizing agent is useful, and we have talked about those agents a little in those cases. But since we've not done it together, and I realize that sometimes there is a question which is asked on, a theoretical question can be asked on the types of embolizing agents. You need to have a bit of a structure with you to kind of go ahead with the answer. So we prepared a short lecture where I'll be discussing the different type of embolizing agents and where and when they are important and a few points about each one of them. I'll share these slides. So definitely the slides will give you a good framework for uh, 10 mark question as well. So the first thing about embolization is how this idea was perceived, and also in between, if you ever have any questions, please share them. We'll try to talk about your experience if you've had with any of these embolizing agents, and if you have a question, I'll be happy to take that also in between. So the first type of embolization, not surprisingly, was also done by Charles Daughter. He's the father of interventional radiology, and he started with angioplasties and angiographies, and then I think he managed to get into the artery. Till that time, there was no specific embolizing agent available because, of course, nothing was being marketed as no such procedure had been done previously. They What he chose was that he took a blood sample and he let it clot. And after reaching the location where he wanted to occlude the vessel, so was for an upper GI bleed, and it was from the right gastroepiploic artery. They able to get their catheter in, and once that clot had formed, they injected the autologous clot. So it was quite a uh, ingenious idea to put that clot in. We know that our blood vessels can get clotted with even minimal maneuvering, and if there's small dissection, there's something small goes, an embolics goes, it can happen. Clots can go and anyways do something like a stroke or a heart attack. All of this is basically a blood clot that forms in our body and occludes the vessel. So he chose that principle, and he decided to do it intentionally. So that is what embolization is. It is an intentional stoppage of flow in any of our blood vessels. So this time it was done for GI bleed, and the patient did quite well. Ever since, of course, then the search for the perfect embolic agent became important when they realized that something like this could be done without opening up the body, because otherwise the GI bleed would require exploratory laparotomy. Anyways, the patient is sick, he is hemodynamically compromised, then waking up for a major procedure is difficult. The mechanism of action for any embolic agent is basically obstructing the blood vessel. So it can be, mechanical obstruction. It could be temporary. It could be permanent. It could be something which is a mechanical device like a coil or a plug or a balloon, or it could be particles that could flow in and occlude the vessel according to their size, or it could be actually a liquid which can either injure the endothelium, or it can actually just occlude and get stuck to the vessel and not let any flow in. So these are the different type of embolic agents. We'll be discussing them one by one. And we need to remember that the sizing is what will cause the kind of blood vessel that will get occluded. So the more distal we go, we all know that if we do a proximal main vessel occlusion, there are greater chances that collaterals will form. So that kind of proximal occlusion usually reduces the perfusion pressure, but it does not per se cause ischemia of the organ bed or the tissue bed. Whereas the smaller the particle, it will go as distal as it will allow the size of the particle. So you can have different sizing of the particle. And if it goes deep and causes, the smallest vessels to occlude, then of course there is no space for any, collaterals to form. As a result, it will cause that tissue to die. So it will not only reduce the pressure, but it will cause the tissue death. So there can be different places where we actually want tissue death, and there can be some places where we just want to reduce the perfusion, to reduce the bleeding, reduce the pressure, allow the body to get buy some time for the body to form its own clots and reduce the bleeding. So that is the important thing we need to keep in mind when we are planning an embolization. What is our goal and where are we trying to embolize? And that will govern how long we want that vessel to stay closed. Is it temporary? Is it permanent? So those questions will finally decide what particle or what mechanical object we are using to cause the embolization. So larger the particle size, the less likely chances of ischemia. The smaller the particle size, the greater chances that will cause tissue ischemia. So what would be an ideal embolizing agent? We have many of them, and perhaps none of them is ideal, and we are still trying to find one which would fit the entire bill. But important thing would be the sizing should be great. It should be like precise. I should know if I'm putting this particle in, what is the size of each particle? Is it same? Is it precise? Or is it going to be a heterogeneous mixture of particles? Non-aggregating, so it should not occlude amongst themselves itself, because otherwise they might get occlude the catheter itself. If they aggregate amongst themselves while we're injecting, that time itself they may aggregate. Transiently radiopaque, so if they are radiopaque, because we have to inject them, we should be able to see where the particle is going, but it should not be a permanent radiopacity or a very high degree of radiopacity, because then while imaging later on, we will find it difficult to image the uh, desired location because it will cause artifacts. Systemically non-toxic. So even if some part of it goes into the systemic circulation, it should not cause toxicity. Although sometimes in cases like TACE, we do combine them with certain toxic materials which can get deposited in the tumor to cause tissue damage. So that is another property it should have. If something can have the secondary property of delivering another agent, so it causes embolization, but can also bind an agent and take it through and deposit it into the place where we want. Then it will not be just an embolization, but maybe a chemo embolization. It should be non-allergic, because again, anything that we put into the body, may it be contrast, medications, injections, anything that we use pharmaceutically, if it's allergic, there's always a chance 1 in 100 that that allergy may cause systemic reaction. So we want it to be hypoallergenic as much as possible. Since we're talking about an ideal agent, it should be non-allergenic, and of course as much as possible inexpensive. Now that can vary to a different degree, but as inexpensive as possible. So as I said, what are the questions that you will ask when you're choosing your embolizing agent? So, of course, one very important thing is what is the size or vessel size. So, it is small or is it large? A larger artery will require something big to be injected. We can't put particles into a 6 mm, 5 mm vessel like the SMA or the brachial artery. And second question, but if it's a smaller particle, you can't put a big balloon in a 2 mm, 1 mm artery. So you have to decide on the basis of that, that till where do we want to reach and what vessel we are occluding. Second thing is, do we want our occlusion to be permanent or is it temporary? I just want to reduce the perfusion pressure for some time. I'm compressing. Maybe there is a small pseudoaneurysm in my femoral artery. Somebody did a cardiac angiography, post angiography, there was a femoral artery aneurysm. So what we do sometimes, we just, pseudoaneurysm is there. We just put a balloon in the femoral neck, and we just at the location of the pseudoaneurysm, and we inflate it temporarily, and most of the time because of lack of flow that pseudoaneurysm will go. Of course there are easier ways to deal with it. Sometimes just ultrasound guided compression from outside might help, but if it is not working, we can always put a balloon across it and wait. If you have a traumatic injury, again you want that bleed to stop, you want that the high flow should reduce for some time, and that will let the body form a clot and decrease its size. So those is just temporary occlusion. Sometimes we